Uh, Next author is Neethu, Latiff.
Good evening. I'll be speaking on the greatest facade in uveitis case series from a tertiary eye care center. So uveitis is the most common ocular manifestation of acquired syphilis, may present as anterior, posterior, panuveitis, retinitis, papillitis, and even scleritis. Because of its varied presentation, it is called the great mimicker. Steroid can be proven detrimental in cases misdiagnosed as non-infectious uveitis. So our aim is to showcase the spectrum of clinical presentation in syphilitic uveitis. It's a retrospective analysis of case series of syphilitic uveitis during the period of April 2023 to June 2024. A detailed uveitis workup along with relevant multimodal imaging was done in all the 4 cases. Case 1, it's a 36-year-old male, sudden onset blurring of vision in the right eye. Vision is 624N18 and color vision was altered. And as you can see in the fundus photo, there's a faded yellow lesion involving the macula. The extent of the lesion is not that visible. So autofluorescence is showing the well-delineated lesion involving the macula and the juxtapapillary area. And fields were showing a central scotoma of the right eye. And OCT showing a outer retinal or outer photoreceptor layer discontinuity or disruption. So topical NSAIDs was given and uveitis workup was advised. And follow-up in 1 month, the lesion spontaneously resolved and the vision improved to 6/9 And you can see in the autofluorescence, the lesion almost completely resolved. And also in the OCT, the outer retinal layer is, there's a restoration of the outer retinal layer. So this patient, the syphilitic workup was positive, all other workup were negative, and this patient was referred to the infectious disease specialist. So this is a case of acute syphilitic posterior placoid chorioretinitis, which is a solitary large placoid lesion localized in the macula of the juxtapapillary area. And this is believed due to the widespread dissemination of the spirochete in secondary syphilis, causing inflammation near the RPE. And the spontaneous resolution of inflammation reflects an adequate ocular immune response to this infection. Case 2 is a patient with a 50-year-old male with right eye sudden vision loss, and he had a right eye panuveitis and left eye was within normal limits. Was advised to do uveitis workup, and he was started oral steroids elsewhere after reviewing of blood test. So after 1 month of starting oral steroids, his vision in the right eye improved, but the left eye vision dropped from 6/6 to 6/24. So this is the fundus photo where you can see dense vitritis of the left eye with wedge floaters. In the right eye, the media is much more clearer, and a OCT showing a disruption of the outer retinal layer. This patient also, the syphilis workup was positive, HIV negative. And so this case highlights the importance of starting an antimicrobial therapy. Steroids can be detrimental when started in the absence of antimicrobial therapy. Case 3, a 47-year-old male with history of sudden onset diminished vision in right eye since 2 weeks, and vision in the right eye is 6/12N12. So there was a bilateral retinal vasculitis, but in the left eye, we can see a retinitis patch involving the infratemporal arcade, and this had a ground glass appearance. And also over the retinitis patch, there were few punctate retinitis lesions. So when we carefully did a systemic evaluation, he had this sort of maculopapular rashes in the palms and the soles. And OCT showing a nodular or a pyramidal deposits in the RPE, and there was a RP hyperreflectivity. And OCT section through the retinitis, that punctate retinitis lesions was suggestive of a superficial pre-retinal precipitates. FFA showing disc leak with patchy hyperfluorescence, and OCT through these patchy hyperfluorescence was suggestive of more of nodularity in those areas. So after a month of treatment with benzathine penicillin, you can see the lesions has almost completely resolved, and the vision is maintained very well. This was the follow-up OCT also showing the nodularity has decreased following treatment. So it's a case of retinitis with pre-retinal punctate precipitates. So this case emphasized the importance of systemic examination in any case of uveitis. Ground glass retinitis associated with retinal vasculitis and punctate pre-retinal precipitate is a hallmark of syphilis. Excellent response to treatment with benzathine penicillin, and in syphilitic retinitis you get almost like a ground glass appearance rather than what you see in ARN, and also the healing pattern will be in a mottled appearance. So case 4, a 37-year-old with acute episode of redness and pain. He had a large nodular anterior scleritis of the right eye. His RPR-TPHA was positive. So nodular scleritis is a very rare manifestation of syphilis, but in our case, nodular scleritis was the initial manifestation of syphilis. So this great imitator should always be considered in the differential diagnosis of scleritis. To conclude with, the great mimicker cannot pretend anymore. Multimodal imaging has a pivotal role in the correct interpretation of clinical findings. Nodular hyperreflective elevations of the RP, disorganization of the ISOS junction characteristic of syphilis, ASPPC, ground glass retinitis and punctate retinitis represent the hallmark of ocular syphilis, and is always important to rule out infective etiology in any case of uveitis before labeling it as a non-infectious uveitis. Thank you.
So did you make the diagnosis clinically or by lab investigation? Was it positive in all the cases?
Sir, like in the third case, which I said, like the macular papular rash and all that, it was more towards syphilis. So in those cases, I could make out that it is a syphilis case. But the scleritis and all with lab only, sir. The scleritis, the patient who presented with the nodular scleritis, because it's a very rare presentation of.
So among these 4 cases, how many of them turned out to be lab positive?
All the 4.
All 4
yes,
of them.
Yes, sir, all 4.
No steroid.
Steroid, sir, actually what happened was that all these patients were lost to follow-up. I think most probably because we kept a follow-up, but through telephone only, but patients were not willing to come back because I think they were better with the treatment. So we didn't have much of a follow-up.
So with the antibiotics?
With the antibiotics.
You started the steroid or not?
We didn't start actually, sir. We didn't start. Only that pan-uveitis case we started with the steroid.
That patient was on steroid from outside.
Yes, sir. That patient was